I am recording, so I'll send this out tomorrow. Once again, thank you everybody for joining. Um, Today will be a fun conversation. We finished round one of the Delphi, closed on Monday. We haven't had a whole lot of turnaround time, but myself as well as Smitty have been able to kind of pull out what we think would be most beneficial to discuss today when it comes to specifically the addition of um, recommendations and then comments for how we want to collect certain elements and the potential of adding new elements. So I'll very briefly be going over the overall results, and then we'll kind of break down a few elements, and then Smitty will help me kind of talk through those elements and what kind of decisions we need to make in order to start building out for round two. So after we go through those two things, then we'll talk about next steps regarding how round two is going to function. And then, of course, if anyone has any questions about the process overall, we can handle that throughout today's discussion. So first of all, round one results. There were a total of 90 different data elements / definitions that you all looked at, which is quite a lot. It's the most that any work group has reviewed so far. So I really appreciate everyone taking the time to go through the Delphi survey. The vast majority of you completed the entire survey. So thank you so much for taking the time to look over that, especially during the holidays. Of those 90 elements, we had 25 reach consensus for inclusion. Once again, consensus was 80% agreement. We had 2 for meeting consensus for exclusion, and then we have 63 still in the Delphi that we will continue to look at in the next 2 rounds that did not reach consensus. Regarding kind of the next round, all results will be displayed in round two, so I'm not going to take a whole lot of time looking at every single element today. Whenever we start round two, for every single element, you will be able to see whether it reached consensus. If it did reach consensus, that element will continue to be in the Delphi survey. However, you won't be able to rank it anymore for inclusion or exclusion, but you'll still be able to view it, which is helpful. So that way, all the reviewers can have an idea of what will already be in the NTRR. And then if there's other elements that are similar, we can see does this one element cover this particular topic, or is there the need for other elements to more comprehensively cover the specific topic? Of course, data elements that did not reach consensus will display in the survey again. You will also receive data on how close that element is to reaching consensus. As a reminder, 80% is needed in order for that element to either reach consensus for inclusion or exclusion. The group decides that they don't want that element to be adopted. Then, of course, all of the comments that were submitted for round one will continue to display. I'm really the only one who's seen all the comments from round one, but now you all will be able to view each other's comments from round two. They're all anonymous, but you'll be able to see kind of the rationale for why other reviewers are recommending specific elements. So as I said, I'm just going to go over this kind of very briefly because you'll be able to see this when you go into round two. These are elements that reached consensus. Eventually, when this Delphi is completed, we'll have a full printout of everything that's reached consensus, the definitions, the permissible values for them. But I just want to use today to just give you a broad idea of what type of topics are coming to consensus so far. So here for the structural determinants, we have a few regarding housing and homelessness. For social status, we have a few income, incarceration, and then a 2 that are paired from NIH regarding sexual orientation. For intermediate determinants, quite a variety of topics. We did see some promise measures come through when it comes to social connection and isolation, as well as quite a few NIH um, topics. This one specific element, the way that that question is asked, kind of hit a lot of the different topics. So we had this NIH element, economic stability and social needs, that kind of hit on a lot of different topics that were in the Delphi. And then finally, when it came to toolkits and then the medical terminologies, we've had one toolkit reach consensus and two of the three medical terminologies. These are things regarding the medical terminologies. These are things that kind of at a later date we can discuss how we'd like to ensure that this is collected. Olga and I are kind of already brainstorming this part of the process. It's a little bit more complicated on regarding how this information will get collected, but just as to keep everyone updated that these two have been reached consensus for wanting to make sure that we can include these data points. So those are the overall topics and elements that reached consensus in round one. You'll be able to see those when you go into round two. But there are some round one elements that will need a bit of discussion here. I'm going to start by covering very broadly a few elements that we know we are going to add into round two based off of feedback. And then there's going to be some that will require some discussion regarding whether we want to, or if we do want to, how exactly do we want to go about adding it into the Delphi. Very quickly, there was a little bit of overlap between the topic of housing and homelessness and then living conditions. So we got some more recommendations for kind of both of those. Some recommendations being a track TBI study with a variable living situation, and then also the prepare toolkit, a specific question related to feeling safe at home. So because those were just very directly recommended by users, those will be implemented into round two. And then now we get into, or one more item that came up quite a bit was geographic information. We had quite a few users who were interested in getting as fine of a detail when it comes to geographic information as possible. So I'll be working with Olga regarding how detailed we are kind of allowed to get within the NTRR system regarding things like census tracts. It was recommended by more than one of you, so that's something that we hear you. We looked at the comments, and then we'll be providing recommendations after internally meeting prior to the release of round two. That being said, this is the first element where we have kind of I think it's important that we kind of discuss it. Veteran status came up as a topic of discussion from our literature review. There was the kind of asterisk here, footnote with this element in the survey for veteran status, that there was no specific veteran status element that was found in terms of it already being collected in a very specific way from our literature review. However, veteran status can be determined using health insurance status, which is an element that is later discussed in the Delphi. So we had some comments regarding that. One being, understanding that that's fair, that it is, potentially we can look at health insurance, but not all former military service members are eligible for health insurance through the VA. And then we had another user who was also very interested in collecting veteran status, specifically getting into what military branch and when was this person in the military, serving in the military. So yeah, this seems like something that the group would be interested in collecting, but we didn't get any specific feedback on how this could be collected, or if anyone knew of any existing data sources that defined this element. So that being said, Smitty, if there's anything else that I missed regarding this element, please let me know. That's my understanding of where this element currently stands.
Yeah, I think the one note that I would add is, understanding that our scope, we're having some scope group, we've got a lot of elements to look at. I think the specific guidance we're hoping for is understanding this as a social driver of health outcomes, as opposed to like an epidemiological measure, like exposure to Agent Orange, for example, as kind of what we're after, with the branch military. But if I'd love to hear from the group about, what is it that we are getting at by trying to get veteran status as a social driver of health, and any leads on specific measures, as you said, Nick.
Well, I mean, I would just say that, I mean, they're exposed often, right? Exposed to different stressors that civilians may
Mhm.
not be exposed to. And, it's well known of the, uh, you know, behavioral health challenges that veterans are often experience that often may be related to the occurrence of you know different situations that they may be in to experience trauma. And so, I mean, I think that I have put a note in there of like, what, because I didn't know of any specific question on how to get at veteran, and so I had put a note in there about just using the definition and making it a yes no question. So I that was just my suggestion
Mhm.
that I had put in there.
Yeah, thank you. It's good
I don't
information.
know if that's helpful.
Yeah, I was thinking along those lines too. I mean, I maybe for a study like focused on quote unquote civilian trauma populations, maybe this would be the right level of analysis, right? Just some quick and dirty assessment of is this person a veteran? But
Mhm.
for a study that's actually focused on veterans, this wouldn't tell you much, and you'd probably want to focus there. I know there's a number of questionnaires on military ex related exposures, right, that would be more relevant if that's but it would just depend on the study. I've never included this variable in a study of mine. I don't know that I have a good reason to promote it based on any experience or research I've read, so maybe it shouldn't be recommended, but it seems like in some studies it might be relevant. But again, maybe care more about actual exposure. I don't know. I don't feel like I have expertise in this particular topic.
So it may be one of the things that Nick and I thought about, and with all of these is, what is kind of the piece that we really need for this working group? And this could be one of those things that we say, hey, we probably need another working group at some point to dig into veterans in particular. So that's kind of what I'm hearing from Monique and from Lynn is that maybe we get kind of that initial, make sure we actually understand, were they a veteran, yes or no?
Right.
And then that those additional very specific measure nuances of what kind of exposures, what kind of trauma, what kind of stressors they might have exposed to and when, needs to be a deeper, more specific and expert group that they
Right,
can
I
get
would agree. Are you a veteran or an active military service member, right? Like, I think if we don't have enough expertise in this, then we shouldn't be making recommendations.
Thanks for mentioning that, Smitty. That's, I think, a great point of our discussion the other day, which was kind of knowing how deep and where our role kind of stops. And this being a very broad topic, I think that it's fair for us to err on the side of keeping it very general and then allowing for, or even recommending, at the end of this work group, hey, these were some of the topics that we felt are important, but maybe there should be another work group to look at these specific topics more in depth because we understand that they're important, but there's so much to them. I will jot down, I heard kind of two versions, one being just a yes, no variable, and one being the option to include, you know, I'm a veteran, active, active versus non-active. Do we want to make that distinction, or do we want to stick with the yes, no for this first kind of attempt at collecting this data?
Personally, I think it's easy to have that one item that's, are you currently or have you ever been a vet in service? And it's, I'm a veteran, discharged, I'm active duty, or I've never served.
Okay.
I don't know the exact language on it, but I think something like that probably captures the level that we need and we're discussing here, consistent with how some other sources have done it. Maybe Lynn and Monique, if y'all know of any examples of someone asking that question in a really good way, we could borrow from that rather than creating something from scratch.
Yeah, I would want to ask someone who's actually like in the VA, like what would be relevant categories here? I just don't know. You know.
I had put in the survey the definition that the I don't know if that's helpful. but it's their definition of what a veteran is. So I'm like, why not use that?
Yeah.
Yeah, so that may be a good
I'll
place to
pull.
start, Nick.
Yeah, I'll pull
Yeah.
that. As y'all can imagine, with 90 elements and everyone leaving comments, we don't have everything included here, but thank you for providing that info. And I'll use that as kind of a starting point. And once again, this is just so that we have something that users can actually then, rank and vote on whether we want to include, because right now we don't have anything for users to even select from regarding this particular topic. So I think that's a great starting point, and I'll draft an element specific for that using that text that you've provided.
And I wonder if Travis would have a recommendation here.
I'll just also add, I guess I'm torn and I keep thinking about different domains different ways, but are we here to make recommendations based on literature and science in the trauma space, or are we free to make, because I think this one is one where maybe it's a suggestion more because it seems like it might be a proxy variable for important exposures, but we don't really, if there's no literature on a variable like this contributing to predicting an outcome, again, maybe we just don't make a recommendation, while we do acknowledge that this is an important area for another group in the future.
I wouldn't say that it being shown in the literature is required. If it's something that the group just feels, as you said, has a role, even if this is just kind of a starting point of that role. Well, thank you all for that feedback for that element. The next one, Smitty, if you want to get into this one is kind of related to how are we actually defining police involvement. There's a couple of different ways that people kind of took this question. And we can define it in multiple ways. But if you want to go over this one with everybody.
So, and this may be a longer conversation. We got a lot of great feedback on how to think about capturing police involvement. I think the question I wanted to kick to the group is, what are we interested in here? I mean, there's other demographic variables that get to some socioeconomic status. We've got other pieces in our adopted SDOH that get to that. There's this great question from Prepare about have they been incarcerated in the past. But there are also, I think there were a handful of comments that kind of spoke to like whether the police were involved in the actual injury that we're looking at that brought the patient in for treatment. And what people think that we really, as the group looking at social drivers of health, what is it that we want to be recommending something around police involvement for a traumatic injury for a patient? And what's the, like, what do we think are the important pieces to really understand about how police might be involved in a patient ending up in the hospital from an injury?
I can explain the second point here on the side, because I think that was my point. I mean, there's a wealth of literature from neuropsychology and other areas of traumatic brain injury that being involved in litigation related to an injury, it changes someone's motivations. It tends to be associated with increased, poorer clinical outcomes, right? For reasons that aren't well defined, but there's just so much literature on it. I think something to do with legal involvement from the injury makes sense to include.
Any other thoughts? Okay. Well, it sounds like, Nick, we could dig in a little more to the comments. There's probably a few more concrete suggestions we could look at. But including like prepare in the next round could be a good place to start. And if there's other measurements from this other article or others in some of Lynn's comments, we could include those and see what we end up with. And the main end up recommending there's more room to look into this if it's an emerging field,
Yeah.
as Lynn is suggesting.
Yep, sounds good.
Yeah, most studies just use a litigation related to injury as a yes/no binary variable, which isn't great, but it's
Oh, really?
very commonly done.
Okay.
Lots of data on there on that topic.
That's pretty easy to add.
Yeah, thanks for that. The next one is related to healthcare quality. We have Sweeney and I had a conversation about this, whether we can use surveys and whether that's doable and some complications around that. We do have USCDI recommended as well. We can have a conversation about USCDI kind of towards the end because that's something that was brought up more than once, and I've already begun discussions with Olga at FitBur Ops potentially on how we can include that or how that's already being collected in the system. So that's one of those kind of more complex question or more complex topics that we can definitely get into. But Smitty, you want to jump into this one regarding surveys?
Yeah. So I mean, I think this is kind of a similar question to before is what are we kind of after for social drivers of health? And like I think this is a really important point of looking at patient satisfaction as some of that because that is something that's used, even though there's some debate about what that actually means. And curious to know what people are thinking. Is it that we want a mechanism to incorporate data from these other sources, or is it that we want to make the questions available to be collected, as new data in a study that's using this set of common data elements?
I was confused. Sorry, y'all. I'm triple booked sometimes on Thursday afternoons, but one of my meetings ended, so I can like be on camera. But I was confused about this one because like if we're thinking of like I was thinking about like healthcare quality as almost more of like some of the HRSA like healthcare desert sort of things, right? Like almost more tied to like zip code. Like there are no psychiatrists in this county, therefore we can it's sort of more of like maybe like access to quality. It's like I guess maybe a little bit more of the healthcare access because I was trying to think about like, well, what's in an EHR related to healthcare quality and do we trust it, right? Because all of our healthcare systems have 1,000 metrics, and if it's about physician productivity, they tend to be terrible. But if it's about patient satisfaction, they tend to be really high. Or in the meeting versus public, right? Because it's so kind of squishy, and so I wasn't sure. One, thinking very practically, like, how would we use this? Like, I don't know. I think I would probably always have a big asterisk and maybe like not use this variable unless there's some sort of mystery objective healthcare quality variable that I don't know about. And the bar always moves, right? And so it's like last year we were bad, but this year we're good, but not because we did anything different, just because like they moved the bar because everyone was failing. And so again, I was kind of more of like the quality of healthcare that exists in the community, like provider shortages, specialty shortages, that kind of stuff, as opposed to like individual quality.
Mm-hmm.
Yeah, it's a
Yeah, those
very
kind of
amorphous topic, right?
Well, these kind of place-based drivers are a little more straightforward to incorporate. We're having some conversations about, as we're talking about how granular can we get with geographic data, how can we include, like, can we have a lookup for, an area deprivation index? Or is that something someone has to go and get themselves and then put in? Um, uh, a similar place-based driver for healthcare deserts, I think is more straightforward to include in our Delphi. Then it's the question of, can we have the granularity to get it to a mechanism to make it easy for someone to incorporate? So Nick, that we could add that to the list with ADI and AVI and
That's more about like access to care, right? And
But
mhm.
it can
how
be quality
proximity.
because you can have access to care. Like you can have in general, you're not medically underserved, but there's zero mental health providers, right? Or you have shortages in like certain key metrics that may or may not be related based on sort of like the research question. And we see that, right? We have counties in Arizona that are like pretty good as far as like providers, but they have like no primary care, right? And so it's like, well, if they're not necessarily flagged as medically underserved, but they're flagged as like sort of a provider shortage on one of the HRSA maps. The nice thing about those maps are like usually based on county, which helps, right? Because we're not really looking for like the granularity of like Smitty, like the Sende project, right? Where they're trying to like geolocate specific neighborhoods is county based, which means an entire hospital is probably going to have that metric because they're probably pulling from their county. And so it's a little bit less patient driven and a little bit more of like healthcare setting driven, maybe.
Mhm. Yeah, I see Heather's commented using rural urban community area codes. I think that was in one of the comments, Nick, that we were looking at on the side in addition
It
to some of the other variables to see how the
it
mechanisms to
was,
include
yeah.
those.
Yeah, it was.
Yeah, I added that because that's something we use a lot. I mean, this healthcare quality, and I do social determinants to rural trauma care, so I'm using these kind of metrics a lot. So I get what you're trying to say here, but um, that you can't get granular with the zip codes with the de-identified data set, but you can use RUCA scores. That would be
Mhm.
awesome.
So we may have kind of two branches here. As Lynn has pointed out, it's really important to look at some of these other dimensions. But as we're digging through USCDI to find specific variables we could put in this article and a few of the other comments, those place-based drivers, RUCA scores are things that we know how to put them into the survey for right now. So we can kind of have two places we're heading with this. This is a great link, Lynn.
Yeah, I
Yeah,
love the
helpful
RUCA
framework.
score. I think that's really useful. And then Lynn, to your point, yeah, that squishy, squishy quality. Like
Yeah. I
yeah.
think like structural things that, right, about like where you live and what healthcare is around you. Those things I think are social drivers of health, whereas anything that's more of an outcome, like I don't know, length of stay in a hospital, that's more of an outcome that maybe is not in our scope.
All right, I think we have a plan of attack for that, Smitty.
Yes.
I believe this is our last one when it came to psychological assets. Promise was brought up. There were some promise questions on the survey in general, but I think I'm going to pull in pretty much all of the promise that are somehow related to mental health into the survey because I know there are some that we missed. I will say that there is an outcomes work group that did include some promise measures. So I'll be sure to review those as well for what, outcomes measures specifically have already been recommended for adoption. And then we'll be sure to include other promise measures related to this topic in the next round. We do hear is this an outcome of social factors than an SDOH? And that I think really comes down to how the CDE steering committee originally kind of defined this group. And we are kind of still, as we go through this process, kind of figuring out exactly where our scope is and how far we want to go into certain realms. Anything else to add on this one, Smitty?
I think that the one of the piece, I mean, this was originally kind of a broader category, and keeping in mind that we're kind of using this framework to give us a little bit of structure given how many CDEs we're thinking about. And so they don't always fit perfectly, just as we saw with the last one. But there's also some comments around self-efficacy and optimism. And whether wanted to get a sense whether people think like these are psychological assets that we need to be thinking about as social drivers of health, or if these are things that might be beyond our scope.
Personally, I think it's tough if we start including psychological things. Basically, we're talking about making it psychosocial, right? Instead of social. I think that that expands the scope to a degree that's so unmanageable and overlaps substantially with other working groups and initiatives that are doing a thorough job of looking at psychological outcome measures.
Mm-hmm.
My only concern, because I do agree in like the large scope, but like if you're thinking about things like acculturation, a really good acculturation measure should include things about like self-efficacy and even things like religiosity, because those are drivers of sort of like health narrative and can be drivers of like self-perception in relationship to the health. So I don't know if it's necessary, to your point, but I do think that they are social factors that drive health decisions and can impact outcomes. And so some of them are useful. I was thinking about them more of like sort of the social, like as a marker of like they can help us sort of understand someone's in relationship to acculturation. But if you don't have the rest of the pieces, it may be fully irrelevant, right? Like it may not matter.
Hmm.
But we could make an argument for not doing it and just say we're using the social ecological model and we're not doing intrapersonal. We're sort of starting at the how an individual interacts with the outside world, and that we're assuming that goes somewhere else, or is less of an impact, has less of an impact on outcomes than the others.
Does anybody object to that? I kind of like that framing of socioecological model. It's kind of nice, evidence-based way of kind of drawing a line around our scope. Does anyone object to that, or does it feel wrong to anybody?
No, and I agree that for me, the intrapersonal are the ones that I struggled the most with and felt like didn't fit in our scope. So what
I
Karen
was also thinking very practically, how are we going to know? Like if,
Yeah.
right, like if unless they've filled it out and we've asked them. But yeah, I agree. I feel comfortable sort of drawing a line because like you, Lynn, I felt very like confused about some of those intrapersonal. Like I can see the value, but also like the value is inherent in the context. And they can also be potentially misused, right? And I think that we also maybe want to be a little bit protective of if somebody who's not coming at it from a social determinants of health framework is looking at an optimism or like religiosity question and is going to potentially like misuse that information because they're not using it correctly. I think that that's maybe also another rationale for removing them.
So Smitty, would you like you and I to kind of go through and delineate what we think should falls outside of the scope, and then that way we can update what gets included in the next round?
Yeah, I think socioecological model gives us a nice framework for that.
Okay.
And then you'll be able to get the validation through the next rounds to make sure that we're keeping in line with what the group thinks collectively.
Sounds good.
Absolutely.
At the end of the survey, there was just kind of an open text field where users could then put, any additional elements that you think or comments regarding the Delphi. As mentioned earlier, you SCDI was recommended for more than one element. And as I said, I have already begun discussions with Olga on the collection of USCDI. This may potentially be a decision for a group above this group as to whether we want to go down that road, because essentially if this group decides that it's something that it wants to do, that may have ramifications on a lot of other elements that have already been adopted in the system, and us needing to kind of circle back on those elements and inputting codes for those as well. So that discussion is at least started. We'll have, I have a meeting with the executive steering committee tomorrow. So I will be bringing it up with them to kind of pick their brain on that as well. But we definitely hear you when it comes to the value that those provide. We've kind of, the middle comment here, we've kind of handled throughout this discussion regarding where we kind of are drawing our line for the scope. So thank you all for that conversation, as well as, there are so many other groups that are looking really in depth at some of these topics. So let's let those groups do that work, and then we can circle back and see what their recommendations are down the road, and then, go from there when it comes to determining what will be adopted in the system. And then finally, the third comment was from Olga, who's our kind of FIPR, design in terms of how the repository is actually structured. So hearing that, low ink and snowman are recommended by this group, at kind of a later time, we can determine how exactly we want that to be collected and reported in the system. There's, of course, some beginnings of collecting elements in that way in FIPR, but we'd like to kind of save that, keep that in mind, but kind of save that for a later date, and let's focus on kind of what elements do we want to ensure are included in the next round for the moment. Anyone else have any additional questions or comments regarding round one?
That was way easier than I expected, this discussion. So good job to the organizers. Wow.
It's all Nick.
Well, thank y'all for, of course, doing the survey. Is quite a bit of data. It just, as y'all know, just closed, so we're trying to get through it quickly so we can keep the group moving. Appreciate everybody's, of course, effort on this. Next steps for this group. Of course, we'll be now going through the discussion that we had today and making those changes, whether it's regarding creating these specific elements, or looking at delineating our focus and removing some things. So we'll be working on that. Myself, Olga, as well as Smitty, on getting round two ready for everybody. The idea is in about 2 weeks, we'll be able to, will hopefully give us enough time to make those changes, and then we'll be able to launch round two, which will work the same way as round one. As I said, data elements that reach consensus will remain, so you'll still be able to see what the group has approved of, and then we'll continue to work through the Delphi again. If you, by chance, didn't get a chance to do round one, I will let you know now. When you go into the system, you won't be able to see anyone's feedback until you've completed the survey one time. So if you haven't gone through the survey, it will force you to kind of put your responses, since it doesn't have any responses from you, before it will allow you to see what other users have put regarding comments and regarding what the consensus point is. So just keep that in mind. I will reach out once we are ready to kind of launch this round, this next round. I will be reaching out before then, of course, as we kind of make these changes. If we do have questions from the work group, we'll be reaching out to get y'all's feedback. And then you will continue to kind of receive invitations from that info at Calibrum from Pam. So she'll be the one who will be continue to kind of send you a fresh link, so it's just at the top of your inbox. So we'll continue to try and link those. I'll let you know that the survey's coming, and then Pam will immediately kind of send it out to you, and then we'll run it back round two. Any other feedback or questions for me at the moment regarding the process?
I just will add one quick comment. As I was doing the survey, I was becoming increasingly sort of pondering what the scope of like the CDE would be for. I think I come from a perspective of doing a lot of acute trauma studies where there's a single index injury, right? And so some of the questions that were like work status pre-injury and post-injury made sense. But then I also think about there's probably a lot of studies out there that aren't focused on a concrete event. And so, is this kind of intended to be for everybody and people doing maybe, I don't know, like military research where you're talking about people who had a lifetime of different exposures and you're like, I don't know. I was just curious if we think this is mainly for sort of acute trauma studies or I don't know.
Nick, do you want to take that or should I?
That's you can take a shot and then I can clarify anything.
Yeah, so my perspective is there is a lot of focus on acute injury, but I don't think that's all of it.
Yeah.
I think the way to approach this is remembering we're not mandating everyone has to use all of these or people can only use these. We're saying this is a core set of common data elements that we want to help standardize across trauma research, whether it's acute or chronic or long-term outcomes, to help increase the interoperability between studies to make it easier to have secondary use of the data. This is a starting point. This isn't the entirety of the work. This will continue, I'm sure. There'll be another working group in the future. How's that sound, Nick?
That's great. That's as you said, this is the very infancy, and it really just comes down to I think we're better off having kind of a broad perspective if it's related, it could be related to trauma in any type of way, not necessarily specific to the acute environment. And as you said, we're already in works with other potential working groups that are already being kind of tossed around as being developed to continue to, as you say, set these standards for how we want to define things to just ensure that the studies that are going in here are defining things in the same way, so we have that interoperability, and we can really build out the system and do high quality meta-analyses.
Yeah. Okay, great. Second and final question. Can you remind me, sorry, can you remind me how much, if any, formal conversation or communication is occurring between this group and the NINDS, TBI, CDE working groups?
This work group specifically, we haven't begun any conversations yet. The Dr. Encini is on our executive steering committee, so she's well aware that that this work group is going. I know she's very involved in everything that's going on with NINS. There was some overlap with the outcomes group regarding NINS elements versus what the outcomes work group was recommending. That's kind of all the information that I have regarding that.
Okay, I
Would you
agreed
like to share?
I agreed to chair a working group for that's gonna get started soon, I think. Focused on I think my group might be, I don't know, patient characteristics or something. So I imagine some of the variables will overlap with things that we're talking about in this group, and I'm just kind of curious what the impact of that might be. So anyway, but I understand that the working groups are about to get launched for that initiative.
Yeah, I think it would be great if we could, collaborate or at least, keep each other aware of where we are in the process, because within the kind of BRICS system, of course, anything that's adopted by NINS is highly recommended to be adopted by us in the creation of the NTRR. Understanding that now we have work groups kind of in different phases of their work. But by all means, if that's something that you're going to be launching soon and be very involved in, would love to try and align as best as we can.
Yeah, agree.
All right. Well, thank you everyone for your participation today. I will be sending out meeting notes as well as a recording of this for those who are unable to attend. And then just be on the lookout for correspondence regarding some changes to the Delphi as well as the Delphi round 2 being launched.
Hey, Nick, stay on with me, okay?
Oh, yeah, we'll do Pam.
Okay, thanks.
Thanks, everybody.
All right, thanks.
Thanks, everyone.
Thanks all. Bye.
Right.
Hey, Nick, just give me a second to turn off my treadmill so I can concentrate.